Greetings to all participants. The topic that we will be looking into shortly would be on localized muscle invasive bladder cancer, looking into bladder sparing approaches. The following are my disclosures, and these are the learning objectives. So, at the end of this lecture, we would hope that you would be able to understand the principles of bladder preservation, to understand various approaches of bladder preservation, understand evidences supporting bladder preservation in clinical practice, as well as to understand the evolution of technological advancements in bladder preservation. So, as an introduction, it is vital to understand that the golden standard for management of muscle invasive bladder cancer is actually neoadjuvant cisplatin-based chemotherapy, followed by radical cystectomy with pelvic lymph node dissection. However, morbidity with radical cystectomy is quite significant, with early complications such as infection, bleeding, wound breakdown, thromboembolism, and late complications such as chronic urinary infections, bowel obstruction, urethral strictures, incontinence, and retention. And there is a very strong patient preference for urostomy-free survival that has actually guided the development of bladder preservation strategies. So the first bladder preservation strategy is transurethral resection of bladder tumor, or TURBT. Now, TURBT alone is acceptable as a standard treatment in superficial bladder cancer, which is typically the T1 tumors. Visible complete TURBT may not be truly complete, and the assistance of fluorescent-based cystoscopy may be helpful. In MIBC, careful patient selection is rather crucial because although the bladder is managed locally, there is a 20% risk of pelvic nodal metastasis, even with detailed staging. So there is a trial by Solsona with 133 patients that looked into TURBT alone as the treatment for bladder preservation, and 10-year cancer-specific survival is reported at 79.5%, but 10-year overall survival is less than 40%. Another study published by Her et al., looking at 99 patients managed with TURBT alone, the 10-year cancer-specific survival is around about 76%. See, the outcomes that are reported here with the TURBT case series are generally inferior to radical cystectomy. Therefore, radical cystectomy still proceeds as the treatment of choice, and TURBT alone is to be advised with caution as an approach for patients with muscle-invasive bladder cancer. Radiotherapy alone is considered to be inferior to chemoradiotherapy and radical cystectomy. And there are multiple controversies revolving around the topic of radiotherapy. The first is, of course, with regards to the schedule. So should we follow the American way of split course radiotherapy with interval cystoscopy, or should we follow the European way of continuous radiotherapy? I think due to various poor outcome with split course radiotherapy, I think most studies now would then advocate the use of continuous radiotherapy. In terms of target delineation, should we do a partial, which is a GTV-based contouring, or should we do a whole, which is CTV-based whole bladder irradiation? Should we then include only the bladder for radiotherapy, or should we include a pelvis with a bladder boost? So these are some of the outstanding questions, and there are no clear answers to the topic of target, as the studies in combined modality treatment that will be shown later actually has a combination of patients treated with various targets. So the first ever trial that showed that chemoradiotherapy is better than radiotherapy was the BC2001 trial, which is radiotherapy with or without chemotherapy in muscle invasive bladder cancer. So this is a phase 3 randomized controlled clinical trial run across 45 UK centers between 2001 and 2008, including patients with T2 up to T4A and not M0 disease. The local regional relapse-free survival was improved with a hazard ratio of 0.61, and the invasive local regional relapse-free survival was also improved with a hazard ratio of 0.55. However, overall survival was not improved with a non-significant 0.88, and bladder cancer specific survival was also not improved with a non-significant hazard ratio of 0.79. This then led on to the introduction of trimodality therapy, whereby transurethral resection up to a level of R0, if possible, is combined sequentially with radiochemotherapy and subsequently followed by restaging TURBT as the surveillance mechanism. The criteria for trimodality therapy vary slightly across the various international recommendations. So looking into the NCCN guidelines, EAU guidelines, AUA ASCO guidelines, and ASMO guidelines, the predominant criteria would be patients with T2 and T3. Typically, most guidelines would exclude the T4A patients, but ASMO somehow recommends the T4A patients to be included. It is also absolutely important for the patients to be clinically node negative and clinically metastasis free. There should not be extensive carcinoma in situ, although focal CIS is sometimes permitted. There should not be presence of hydronephrosis, and the bladder function should be adequate and good. And there is a preference for small and solitary tumors within the bladder mucosa as per the NCCN and EAU. And the ASMO guideline actually goes on to define further that there should be no prostatic urethra invasion. So if patients satisfy the combination of these categories, then they would be eligible for trimodality therapy. So let's look into a non-exhaustive list of retrospective series of trimodality therapy. So if you would look at the TURBT completion rate ranges between 60 to 100%. The chemotherapy of choice ranges between 5-FU, carboplatin, and cisplatin. Radiotherapy doses ranges from 54 grays up to 65 grays. And that results in a complete response rates of exceeding 70%, and some studies even up to 88%. And salvage cystectomy rate for those with relapses around about 20%. And the 10-year and 5-year overall survival rates are quite decent across these retrospective studies. Looking into the prospective studies, again, the recruitments are quite similar, with a complete TURBT rate of around about 50 to 70%. The chemotherapy of our choice here are a lot more varied, with vinblastine, cisplatin, 5-FU, and gemcitabine, with radiotherapy doses slightly higher in the range of 50 to 64 grays. And this results in complete response rates of exceeding 70% and even up to 85%, and salvage cystectomy rate around about 20%. These studies also show a very reasonable overall survival and cancer-specific survival rates. So the more logical thing to do now is to look into whether TMT is better than radical cystectomy. Of course, there are no head-to-head clinical trials that actually looked into this, which is why we then need to look into the meta-analysis, pulling in all the phase 2 data that are available. There are at least 3 different meta-analyses that has been published. The first meta-analysis done by DiTono actually shows a similar overall survival with similar cancer-specific survival, but a lot more cost-effective approach in TMT and a higher general QOL squares for TMT. This study actually shows that TMT would be favorable in patients who are eligible. Fong et al., which is predominantly a surgical meta-analysis, actually shows that the overall survival and cancer-specific survival were poorer in the TMT group. Zilota et al. Actually did another meta-analysis with a propensity score matching methodology with more than 1,000 patients with similar metastasis-free survival and cancer-specific survival with surgical complications that are low even in salvage with the use of TMT. So we do know that at best, TMT is equivalent to radical cystectomy with a much lower complication rates. So could we then do better in our approach for trimodality therapy? Could each modality be further improved? Of course, TURBT is already very well established, but could the chemotherapy arm be further intensified? Could the radiotherapy be further intensified? Could we then introduce additional treatment, such as neoadjuvant chemotherapy, as we do in the radical cystectomy space? Could we then de-escalate by omitting local regional therapy? And could we also explore biomarkers to see how we can select our patients better for TMT? So, first of all, let's look at intensification of the chemotherapy. And here we have the introduction of immunotherapy. Now, this is again a non-exhaustive list of trials that looked into the combination of TMT with immunotherapy. The complete response rates are fairly decent, around about 80 to 100%, with very good 1 year, 6 months disease control rates and overall survival rates. The adverse event rates are also relatively acceptable, with AEs ranging under 30% in all. And this space has got a lot of ongoing trials into looking into incorporation of various systemic therapies in combination with immunotherapy. And all these trials are eagerly awaited upon. And one such trial is the SWOG NRG 1806 trial that randomizes patients into concurrent chemoradiation and concurrent chemoradiation with atezolizumab. So, in this particular trial, the arms between CRT and atezo and CRT alone were very well balanced, right? And as you can see, the radiation field included both bladder only and small pelvis. Now, in terms of toxicity, we do find that the addition of atezolizumab does not result in worse outcomes as compared to chemoradiation, which is the standard arm. The survival outcomes are very much anticipated. So next, look into how we can improve radiation. So this is a meta-analysis that looks into the role of hypofractionation of 55 grays in 20 fraction versus the conventional 64 grays in 32 fractions. And this meta-analysis shows that there is a favor towards the 55 in 20 fractionation, although the difference is not statistically significant in terms of overall survival, but statistically significant for local regional control. In terms of toxicity, we see that the rectal bladder toxicities are fairly similar in the 2-year period, as well as the 5-year period. Therefore, hypofractionation with 55 grays in 20 fractions is a reasonable alternative to standard conventional fractionation. Let's look into the introduction of neoadjuvant chemotherapy with trimodality therapy. Now, there has been a lot of studies that actually looked into this approach, similar to what has been done in the radical cystectomy space. And it is very, very disheartening to know that neoadjuvant chemotherapy does not improve survival in the administration of trimodality therapy. And looking into chemotherapy with TURBT, omitting local regional treatment, which is the radiotherapy, we do find a retrospective review of 148 patients looking into this approach. And at 5 years, the overall survival is about 86%, disease-specific survival of 90%, and bladder preservation of 76%. And recurrences were rapidly salvaged with radical cystectomy. Therefore, there may be a possibility to omit chemoradiation if patients received chemotherapy and TURBT and achieved clinical complete response. And this approach was further evaluated with the use of TURBT followed by accelerated MVAC and another TURBT, and subsequently categorizing the patients into the treatment based on response. So if there was no residual disease, it was active surveillance. If there were residual non-muscle invasive disease, it was intravesical therapy, chemoradiation, or cystectomy. Those with muscle invasive disease would receive chemoradiotherapy or cystectomy, and those with T3, which is extravesical extension, would go on to receive cystectomy. This was basically a negative study, but what was then observed is that patients in the active surveillance group did not have a worse outcome in terms of metastasis-free survival and overall survival, suggesting that if the patients underwent chemotherapy and TURBT and achieved clinical CR, active surveillance may be a reasonable option. This also then led on to a retain-true trial, whereby immunotherapy was then incorporated into dose-dense MVAC in the chemotherapy phase. And the subsequent categorization of treatment were very similar to retain-1. Now, when we look into the comparison between retain-1 and retain-2, what we do find out is that the pathological response rates were significantly improved with the addition of nivolumab. So there is another ongoing trial, which is Alliance 031701, which randomizes patients into gemcitabine, cisplatin, either 6 or 4 cycles, and subsequently genetical sequencing and molecular stratification to identify patients to benefit from bladder sparing strategy, radical cystectomy, or chemoradiotherapy. And this is an ongoing study. This is the HCRN GU16257 study, which looked into a neoadjuvant gemcitabine, cisplatin, and nivolumab, followed by restaging imaging, cystoscopy, and TURBT. And if patients achieved complete clinical response, they then went on to receive nivolumab or cystectomy, and those with muscle invasive disease went on to receive cystectomy. Now, in this particular study, what was very interesting was that those who did not achieve clinical complete response did a lot better in terms of metastasis-free survival and overall survival as compared to those who did not achieve clinical complete response. And mind you, those who did not achieve clinical complete response went on to receive local, regional, or surgical treatment. So this is a proof of concept that patients who achieve very, very good response with chemotherapy plus minus immunotherapy and TURBT may actually be safely observed. The last bit is to look into biomarker-driven approach, whereby molecular subclassification has given us some idea as to which patients would do better with TMT. So the basal type classification seems to have a better response to chemotherapy than luminal type. CD8 expression tends to predict response to immunotherapy. Tumor mutational burden has been shown to be not reliable, and TGF-beta predicts poor response to systemic therapy. And there has been novel approaches to assess response with imaging using multiparametric MRI, plasma ctDNA, and urinary ctDNA. None of the above have actually been validated for routine clinical application, and current ongoing studies are always looking into these biomarker-driven approaches. Now, just to highlight a little bit on molecular classification for those of you who are interested. So this would be a combination of oncogenic mutations and non-oncogenic mutations that is done through next generation sequencing. And the combination of it then identifies these patients into the urothelial luminal subtype, stroma-rich subtype, basal subtype, and neuroendocrine subtype. And this guides various treatment approaches. And these are some of the subclassifications that are used in trials such as retain-1 and retain-2. And the design for future bladder preservation trials would definitely need to take into consideration patient-related factors such as biopsy, staging, imaging, biomarkers, bladder function. systemic approach such as neoadjuvant, concurrent, and adjuvant approaches, local treatments such as active surveillance versus trimodality therapy and radical cystectomy, and the various endpoints to consider, such as clinical complete response, pathological complete response, bladder intact disease-free survival, event-free survival, overall survival, and of course, quality of life. So, in summary, bladder preservation in muscle invasive bladder cancer provides a solution for local control in MIBC with improved quality of life and intact bladder function. The combination of TURBT, chemotherapy, and radiotherapy, termed trimodality therapy, is accepted as the best current approach in bladder preservation. Evolution of TMT in choice of systemic therapy, radiotherapy schedule, additional therapy, and de-escalation is ongoing to improve outcomes in bladder cancer, and further research in interventions and biomarkers are currently also in progress. So no man is an island, and none of this is achievable with a reliable and extremely cooperative team. So I'm very proud to share with you some of the members of my clinical team, comprising of consultants, medical officers, radiographers, medical physicists, and therapy radiographers. So only a team put together such as this would then be able to deliver successful treatment for the improvement of patients, for betterment of their quality of life and their survival. With that, I thank you for your attention.